Hi everyone, welcome to the School of Health Information Sciences Health Terminology Standards Seminar Series for June and July. My name is Linda Bird and I'm one of the instructors for the Health Terminology Standards Certificate Program that this seminar is part of. Before we get started today, let's begin with our territory acknowledgement. We acknowledge and respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt and Wasanich peoples whose historical relationships with the land continues to this day. Just a reminder that the seminar series is delivered as part of the final course of our Certificate in Health Terminology Standards program. And if you're interested in applying for the next intake that starts in September, applications close July 15th. So you can visit the Health Information Science Faculty Certificates site. So today is the second seminar in the Health Terminology Standards Seminar Series. Last week, we heard from Dr. Price about primary care systems improvements. And over the next 3 weeks, we'll be hearing presentations from Alberta Health Services, SNOMED International, and in the final week, we'll hear more about computable care guidelines. Please note these sessions will be recorded and shared on the school's website. And if you have any questions or comments, please either add them to the chat, add them to the end, or I think Lynn and Peggy are happy for questions along the way as well if you do have any. So today we are delighted to have Lynn Nagle from the University of New Brunswick and Peggy White from the Canadian Nurses Association. Lynn is currently an adjunct professor with the University of New Brunswick, the University of Toronto and Western University. As the founding president of the Canadian Nursing Informatics Association, she has been recognised for her commitment to the advancement of informatics in nursing education and practice. In particular, Lynn has been instrumental in the development, implementation and evaluation of informatics competencies for student nurses, registered nurses and nurse leaders. Additionally, since 2016, she has been the co-lead of the annual National Nursing Data Standards Symposia, focused on strategies to advance the adoption and use of nursing data standards across Canada. And then we also have Peggy White with us. Peggy is a graduate of the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto. She is an experienced healthcare leader with an extensive background in leading clinical standards initiatives across Canada. She is currently a consultant at the Canadian Nurses Association as the National Project Director of CHHOBIC and the co-lead of the National Nursing Data Standards Initiative. Peggy also has numerous publications on the value of clinical data standards in healthcare. So obviously, we're delighted to have both Lynn and Peggy with us today. And with that, I will pass the screen over to Lynn for their presentations. Thanks very much. Over to you, Lynn.
Okay, thanks, Linda. And I will just wait for that to come up. There we are.
Fabulous.
Well, good afternoon, everybody. That's clear, Linda? It's coming through?
Yep, perfect. Thanks.
Okay, great. And it's lovely to be here with you this afternoon. Where I am on the East Coast, it's almost bedtime. So I'm going to make sure that I can stay awake and keep engaged with you for this evening. But it's really quite a pleasure to be doing another lecture for the University of Victoria. I have been involved with UVic for many years and have a lot of strong affection for the program, the graduates, and the work that has been done by the graduates coming out of the various programs. Thank you, Linda, for the invitation. And Peggy and I tonight are going to just take you on a little bit of a journey. Really what we want to do is give you a bit of a very quick overview of where things are at in Canada with nursing data standards, and particularly the work that we've been doing for the last number of years. And I would say that Peggy and I have been engaged in this work since the late 90s. So it's been a long journey for us, over 20 years, and we've had many successes, but we've also had many challenges and many obstacles. And so we'll talk a bit about some of those tonight. and hopefully leave you with a little bit of a sense of where we're at and where we hope to get to in this country as it relates to nursing and clinical data standards as it supports clinical practice. So first of all, I often start presentations with this slide. It's a quote from Florence Nightingale. And it always, the irony of this is not lost, because if you think about the day and time and year of this quote, came out of her book on Notes on Hospitals, but she was striving in those years that she was working in the Crimean War and looking after sick soldiers and trying to figure out, why people were dying, not necessarily of war wounds and mortality caused by battle, but because of other things. And so she was always collecting data and trying to figure out causation of disease and why people were dying. And so when she was looking for data, she struggled to find comparable data. And we continue to struggle today, so we think about, we're almost a couple hundred years later, and it's still an incredible challenge. So for me, this still resonates. And Florence, we always in nursing think of her as the first nurse informatician, because she really did spend her life's work focused on mapping and collecting data and trying to use it in a way that could meaningfully change how people were being cared for in the institutions that they had the day. And she had in her work actually developed something that we've referred to in recent years as the Rose diagram. And you can read more about this, but she actually mapped out, the causes of disease from war versus causes from other things like infection, respiratory and otherwise. But she when she mapped these things out, it actually depicted in this diagram, which was actually pretty creative in the day, showed that soldiers were dying more from many other things than they were from war wounds. So really classic case of showing the power of data, and in a very somewhat rudimentary way, but very powerful way. And so we continue to think about data and the importance of standardizing it, because in our day and age, if we can't categorically capture our care that gets delivered in every setting, who delivers it, what gets delivered, what the outcomes are, if we're not consistent in how we describe the practice of nursing and the practice in medicine and other disciplines, it's very difficult for us to do any data aggregation. And it will be difficult to name what we're trying to understand, to try and influence it, to try and fund it, and teach it and actually study it. So, and at the end of the day, to be able to put it into public policy will be, and continues to be, actually, it is problematic for us, because we learned through the pandemic that we are sadly lacking in consistent data across this country and consistent ways of capturing it and reporting it. So this quote comes from a couple of decades ago, a couple of nurse colleagues from the US who did a lot of work in this space and contributed largely to the development of the International Classification for Nursing Practice. And if you want to read more about that, there's many subsequent pieces that have been written, and there's lots of material on the International Council of Nursing's website about the ICNP, or the International Classification for Nursing Practice. So in Canada, for those of you who are not nurses, and I'm not sure how many of you are nurses in the class tonight, but we have more than 300,000 registered nurses. I wonder what that number is today, given the number of nurses that we lost as a consequence of the pandemic and people taking early retirement. But the number is probably somewhere north of 300,000, and that's including all categories of nurses in the country. And so if you think about all of these nurses practicing in every care setting, nurses are the one health profession that appears consistently throughout the healthcare system. And I think in order to really understand what is safe quality care and the impact on patient outcomes, we need good, consistent, standardized clinical data. And I think my personal bias on this, and I will not hesitate to express those this evening, but I think one of the things that I worry about is that we have implemented electronic health records, across the country, and we haven't taken advantage of the technology, and we haven't taken advantage of the opportunity to build standards in the way that we could. And perhaps you'll hear more about this from Derek Ritz later on in the course, but I think it's very clear to me that there is still a lot of work to do across the country. We have pockets of standardization, but we are by no means anywhere near having a wholesale scaled set of data that represents nursing practice. So a few years ago in our work, Peggy and I created this infographic with the support of the Canadian Nurses Association. And it really is about the importance of advancing essential clinical data in Canada. So we talk about nursing data, but we're also talking about clinical data because nursing data is used by other disciplines. So it's not purely nursing in every instance. So there are data that are shared across disciplines, and there are those that are unique to nursing. But our premise in this infographic is really just to say, if we could collect the same data consistently across the board, and if we could collect it in a way that it transcends boundaries of care so that it gets reused and informs care as patient transitions across care boundaries, then we can share data in a consistent way, not only with one another, but also with patients and families. And as we see more engagement of patients and families in their own
Oops, we lost her.
There, she's coming back now.
Oh, okay, thank you.
Lynn?
Are you back with us, Lynn? She's still waiting to get audio. She looks like she's there, but she's... if Lynn isn't able to join us, you know what plan B is, don't you, Peggy?
I might have to go out and find the slides, but yes.
Oh, yeah. Well, that's true.
There she is.
There she is.
Lynn? We can't hear you.
Can you hear me now?
Yes.
Yeah, we can.
I don't know where that went. Can you see the slides?
Nope, just you.
To share the slides again.
Maybe you should stop your video when you're presenting. I just don't know if that matters. Some people say it does.
Yeah, I will.
Okay.
Apologies.
No
I
worries.
was waiting for plan B, Lynn.
Yeah, Peggy was going to take over if you weren't able to rejoin, Lynn.
It's not, I think you have to let me share again, Linda. It's not letting me.
Oh, okay, no worries. It says that you're co-host.
Okay, wait, here it comes. Okay.
Great.
All right. Where were we? Okay. So I was talking about the infographic and talking about really being in a position down the road when we have a core set of clinical data that's consistent across the board, a core set of data that is consistent across care settings. Because if you think about it, even though there's variations across care settings, there's a lot of similarities, and there's a lot of the same data that gets captured repeatedly across care settings. And so our whole premise is collect that data once, use it for all the purposes in which it could serve, and actually then it puts us in a position to be able to really evaluate the impact of care interventions and create new evidence about what is effective in clinical care and what may not be. And then allows us to further refine clinical practice. And again, it's really an idea of generating new evidence on the fly, evidence from practice. And I've always thought about this as dynamic research. So if you think about in Canada today, the number of patients admitted to acute care and the number of data elements that get assessed on every admission and the amount of time that every nurse spends collecting that data. And then you think about how much that data ever gets looked at again. And those of you who are clinicians, those of you particularly who are nurses, will appreciate the sheer volume of documentation that's required in every clinical setting. And I think we've heard an enormous cry from clinicians over the past couple of years about the burden of clinical documentation. And so it really is incumbent on us to think about how do we streamline documentation? How do we streamline it in a way that we can narrow in on a core data set that tells us what we need to know about patients and citizens as they move from one care setting to the next? Because we're collecting an awful lot of data today that doesn't really ever get used again. And in fact, how many people actually look at it is up for debate. And one study actually showed that only about 25% of these data are actually useful. We have had a number of key events that have happened over the course of our nursing standards work in Canada. And if you see on this timeline, we started this work way back in the early 90s. I, in fact, at the time was a doctoral student and attended the minimum data set meeting in Alberta. That was the first time nurses came together to really talk about nursing data standards. And we had a number of experts came from the States and other parts of the world to come and talk about the work they were doing. And that really was a landmark meeting, which then evolved into the creation of Health Outcomes for Better Information and Care in Ontario, which was in a whole project that was funded by the provincial government. It was originally looking at how do we basically justify the cost of nursing care in this province. And then it evolved into, what if we could create a core set of nursing data standards that could be used across all care settings? Wouldn't that tell us a whole lot more about the value that we're getting for our nursing practice? And so CHOBIC was then the Canadian variant of that evolved and expanded into Manitoba and Saskatchewan. In the late 2000s, we actually did some mapping of CHOBIC, which is a suite of 7 measures, and Peggy will show you a little bit more detail about those measures. But we took this core set of data, which were focused on things that nurses were assessing in every care setting. And we thought this is a logical place to start because these are the things that are important to nurses. These are the things that tell us whether or not people are improving in their function and their symptom management, and overall just looking at their outcomes at different points in time. So being able to look at the same data, the same measures over time was demonstrated through CHOBIC that it was possible and that it could be of great value. And that's where the research came into play as we started to look at some of our implementations of CHOBIC in Ontario and then in other provinces, that we could actually see benefits from being able to track data, particularly from discharge from acute care to following up in home care or long-term care, being able to look at the same measures and see whether people had improved, were they better or worse from admission to discharge, Were they better or worse from admission to discharge in home care, and so on. And then we actually also created a synoptic report to give nurses and other clinicians a snapshot of those measures. And so the measures we're talking about are things like function, symptom management, readiness for discharge, safety measures, falls, skin breakdown. And then we actually, with the mapping that was done to ICMP and SNOMED CT, we actually ended up having CHOBIC included in the 2015 release of SNOMED CT, and we actually had a catalog published by ICMP. In 2017, we did a pilot and with CIHI to see if this data could be abstracted and reported in the DAD with other data being collected. It was demonstrated that was indeed possible. So we can elaborate on any of these milestone events if you're interested, but just to give you kind of a quick sense of where we've come from. And over the past number of years, Peggy and I have been leading these national nursing data standards symposia. And we were hoping, before COVID struck, we were hoping to have a national think tank to take us to the next step. So this is where we are today. And I think at this point, I just want to say that there's more information about the Canadian Nurses Association's stance on nursing informatics, but also on national nursing data standards. So this slide just gives you some links. You can have a look at some of these other information sites, and there is a position statement that alludes to the nursing data standards on the website as well. So, and in fact, one of the outcomes, and you'll see this later, of our work with the symposia was to get a resolution passed nationally for the adoption of some core data standards. And Peggy and I also created this visual back in 2015, which really is our way of trying to demonstrate the potential of having these standardized data across care settings, being able to look at an individual consistently, but also being able to look at organizations comparatively, being able to look at jurisdictions across regions, using the same data, being able to look at things like care outcomes, but also financial outcomes, and more importantly right now, the whole health human resource implication. So is the right provider giving the care that's needed? Are we making the best use of our resources? And we've heard this over and over and over in the last couple of years with the health human resource crisis. And so again, another reason, and a very significant one, for us to be focusing on creating some standards, not only to save documentation burden, but also to make sure that we're using our health human resources appropriately. So we've had 5 symposia, and we had many, many nurse leaders and other healthcare leaders participating. These were hosted at the University of Toronto. And I think we were very purposeful in the individuals that we selected to participate. We had a mix of CNOs, we had people from frontline informatics work, we had academics, we had very purposely invited a group of the vendor community. So some of the big electronic health record vendors attended. So we had a real strong cross-section, I would say, of individuals from all sectors and from all different roles and responsibilities, including some policy people. And really our intent there was to work on identifying that core set of standardized data and to really look at how we could influence clinical practice, administrative directions, education and research and health policy. And really looking at who should be accountable. And the accountability question has always been a challenge. It's been one of our big challenges. And I think it's important to also know that our symposia were all supported by Canada Health InfoWay, the CIHI, and the Canadian Nurses Association. So we had support in a lot of encouraging direction from those groups, but the work continues and needs to continue. So this gives you a sense of who the players were. We partnered with these organizations as the key point organizations for this type of work. We engaged people across the board, and you can see that we also took advantage of wherever there were new EHR implementations happening to try and, get on the back of those to incorporate and integrate standards during the new implementations. We've done multiple presentations across the country. We've published our proceedings. They're available on Infoway's website. They're also available from CNA's website and CIHI. And then we had a number of other products that we developed and have posted on various websites. And we had a number of working groups who have, some have finished their work, but some have continued. So that's really where we have taken this work. And at this point, I think what's really important is that we've taken this to a point where it's not done. And we continue to need people who can help us on this journey and help us to take it even further. And Peggy and I are both at the end of our careers. So we're looking to some of you young folks to step up to the plate here, because I think there's a wonderful opportunity to make a very significant difference in what happens in Canada in this space. And, we have looked to our counterparts in other parts of the world. We're doing pretty well relative to some countries and not as good as others, but I think there's always room to grow. So I'm going to turn it over to Peggy, and she's going to take you through the next set of slides.
Okay, so the next slide, Lynn and I thought we would give you a use case of how this data could be used and just speak to the value of it. Next slide, Lynn. So if you look at this data set, so I don't know, maybe nurses, but other clinicians as well, these are concepts that I think we all assess in all sectors of the healthcare system. How is a person ambulating? How are they managing their hygiene and toilet transfer? The symptoms of pain, both the frequency and intensity, fatigue, dyspnea, and nausea. I always have to say, for people that aren't nurses, dyspnea is short of breath. Fatigue is that tiredness. And it's beyond just I'm tired and I need sleep. It's like fatigue is like, even with sleep, sometimes you think of a cancer patient, they're just fatigued. And nausea, the safety outcomes of falls and pressure ulcers. So we're all assessing those in, like Lynn said, we got both manual and electronic health record assessment, admission assessments from across Canada. Everyone was assessing those. Some of them were a narrative, some of them had a tool that they developed. None of this was standardized. And so by standardizing this information and coding it, then you can collect it and share it. And I think that's really one of the driving forces. And this concept of therapeutic self-care, which when I practiced as a nurse, we didn't assess, but I think, where we are now in healthcare, it's really important about patients' knowledge of their medications and do they know why they're taking them? They recognize these changes in their body's symptoms. Can they manage those? Can they do everyday things? And do they know who to contact if they need help? And we did, Diane Doran in, I think it was 2002, did research. So we have strong evidence that nurses play a role in all of these. So there's evidence to support nursing practice in these. And I think they add value to other disciplines as well. So you think of pain, you think of pharmacy, you think of function, you think of physio and OT. So they add value to other disciplines. And I think it adds value to patients within the healthcare system. As you think we have an aging population, how are we managing their function? Are we managing their symptoms when they're in acute care and preparing them to go home? And these are important things that I think we all have to pay attention to. Next slide, Lynn. We linked wherever possible. We linked wherever possible with the interim measures. And if you don't know about those, here's some information you can check out. But the interim measures, when we started this work in Ontario, were used in long-term care, and we knew they were going to be implemented in home care and community care. And so really it was that visionary work back in the beginning to think about if we wanted to follow a patient across the continuum of care, what information should we collect? What needs to be standardized so that we can look at that patient as they move from one sector to the next sector? Next slide, Lynn, please. So when you think about chronic obstructive lung disease, and the coding there is for the SNOMED code. And so that's the patient's diagnosis. And next slide. And they're admitted to acute care. So they're able to walk short distances, but they're unsteady. They're short of breath. So it's present at rest, unable to manage this bathing alone. And his ankles are swollen. He's very tired, such as he has difficulty performing many of the ADLs, doesn't really know about his meds. And so referrals are made to PT and OT for exercise and energy management, and diuretics prescribed. So for all the CHOBIC concepts, function, symptoms, and self-care, we've put in the SNOMED code. So function on admission is 2 coded, the dyspnea is 4, and the fatigue is 4. So those are just the questions that relate to the fatigue and dyspnea. And then ability to manage his medications, he's not able to. Next slide. So when we have the nurses do this on admission and discharge in acute care, and on discharge, after 8 days, his shortness of breath is less, but he still has some. His ambulation has been assessed by physio prior to discharge, and his fatigue is reduced, and he's more able to manage his activities of daily living and knowledgeable of meds because the pharmacy has been involved. So by assessing those things on admission, those items, functions, symptoms, self-care, we were able to put in an appropriate kind of care for this gentleman to look at preparing him for discharge from day 1. So not the day he's leaving, which sometimes happens, but assessing those items on admission and developing a care plan to prepare him for discharge. Next slide, please. So he's now discharged home. And so we see where he was on discharge from acute care. His function was 0, it was good. His symptoms, the dyspnea was at a level 2, the fatigue at a level 1, and his self-care was a level 2. So on home care admission, 1 week, which is usually 1 week after discharge, he's assessed again. His walking is still good. His symptoms, his dyspnea is 2, and his fatigue is a bit more. He's more fatigued, and his medications is fine. So again, it gives that home care. We know when that patient was admitted to acute care that he had some issues with function, dyspnea, and fatigue, and knowledge of his meds. So the home care nurse hopefully will use that information to look at managing that person and keeping them in the home to prevent readmission rates. And we know for some research done by Dr. Walter Woods back in, I think, 2014 in Ontario, that patients that went home with the high dyspnea level had a high chance of readmission rates within 14 days. And the people that went home with the therapeutic self-care that they weren't managing their therapeutic self, their readmission rates to acute care were much higher. So how do we as clinicians in all sectors use data to look at what we can do to manage that patient and keep them out of hospital? Next slide, Lynn. So when you think about having data, and I think this is where, for clinicians, that we really need to begin to think about looking at data longitudinally, thinking about practice, and thinking of what we need to do to manage people in the home care sector or at home and try and prevent hospital readmissions. So by mapping the data, and this is just very basic way of mapping that data, but we can look at data and use it to inform our practice. And I know at one point when I was meeting with some family physicians, they said, if I had access to this data and know that their admission, there was dyspnea and fatigue levels were poor, then I could use this data in my practice as well. So I think it adds value, as I say, beyond the healthcare team and actually to patients, because at some point, I used to say it might happen in my lifetime, but now I sometimes wonder, patients are going to have access to their record. And what is it going to say about healthcare if in one sector, acute care, they're assessing the function and dyspnea and fatigue using this tool, and next sector, it's a narrative or another tool. And then we give patients access to their health record and say, we really want you to be involved in your self-care. And if we're all assessing information in a different way, I really think that's going to be challenging for patients. And that's what healthcare is all about, is managing care for people over time. Next slide, Lynn. So when you think about this patient and the information that we have and sharing it with the respirologist, so he knows where they are in terms of their dyspnea and fatigue, sharing it with CIHI, which is the Canadian Institute for Health Information that collects data. And again, by standardizing that data and bringing that standardization to acute care and to be able to link that with home care and community data to begin to the foundational pieces for a longitudinal record can be shared with the lab, the hospital, the home care nurse, the GP, and the patient. And I think if we think down the road where patients are managed at home, maybe by nurse-led clinic, virtual care, that patients perhaps can do some of these, complete some of this assessment on their own for their fatigue and dyspnea level. And then the home care nurse can say, we need to go in, or I can look at the data and it's being maintained. So again, giving us that data that we can all talk about in the same way and that we can make available across the system to really inform practice and look at outcomes. Next slide, please. As Lynn talked about this before, that we did map the data set to ICMP as the Canadian Nurses Association was the signatory to ICMP. And, we thought that that was really important. But as ICMP and SNOMED CT have merged, we've also, we're mapped these concepts to SNOMED CT as well. Next slide, Lynn. So when you think, again, when you have data, these clinical data standards, there's ICMP, LOINC, CHOBIC, SNOMED CT, INTERI data, and we're able to have the technology to put them in EHR, to share remote monitoring on portals. But what we lack, I think you have to keep clicking, Lynn. Yes, good. Is comparable, shareable data. So the adoption and utilization of data standards. And I think from the work that Lynn and I've done, we've struggled with people really recognizing the value of data standards beyond their organization. And I think as they implement, certainly from acute care, they implement an electronic health record or home care, they're really just going with what's in that system. They often don't recognize that they need to look at standards across the system. And I think that's a real issue in healthcare. Next slide, Lynn. So when we think about this data in terms of informing the health human resources, we have a demographic shift towards an aging population. We have a rise in chronic conditions, COPD, heart failure, CHF. In Canada, there's a high use of emergency departments and hospital beds. And we have a desire for people as they age, they want to age at home in place. So what data do we need to collect in a standardized way to support that? I think, as nurses, there's an opportunity for us to take on some upstream roles in where we can take charge of the health of people, of populations to prevent hospitalizations. So what data do we need to do that? When I think about a healthcare across the system, having clinical data standards that have value to the clinical team will help us in understanding health human resources planning. What model and mix of teams produces the better outcomes? And I think of, does it matter for function if a physio does the intervention, if an RN does it, or a physio assistant or a PSW? When we take that balance of cost and quality, we need data to begin to ask those questions. I know when I was a manager in acute care, whenever we got money, very rarely, we always added an RN. And if we had to cut our budget back, we lost an RN. But if you think of a large hospital with a respiratory unit, what's the mix of team that will produce a better outcomes? Maybe they need more RTs. Or if a stroke unit in a hospital, or you have more stroke patients, maybe you need more physio and OTs than RNs. So I'm a nurse and I always advocated for the RN roles, but I think we need to have an understanding of what team produces better outcomes. As we think of care transitions, having data to follow that person across the continuum of care, and then being able to evaluate what interventions produce better outcomes. And I think a lot of our practice is based on that's the way we've always done it. And by collecting standardized data and looking at practice, there's an opportunity to really transform care. Again, sorry, go back one minute. If you could just go back, sorry. As we think of the best care setting for care delivery, as hospitals may change and more people managed in the community, what interventions maybe from acute care do we put into home care to look at quality, safety, and costs. What interventions in long-term care can we have to manage patients in that sector? And certainly informing healthcare policy and generating new knowledge and questions and innovations is so important for nursing and for all disciplines and for patient care. Next slide. I wrote myself one or two notes again, for clinical decision-making, what works, and having data collected in a standardized way. I can admit Mrs. Smith, who's an 86-year-old with COPD, and I can have data from other patients in a similar age group with a similar diagnosis. The EHR will present me with 3 or 4, 5 interventions, and I, as a nurse, can use my knowledge and assessment of that patient at that moment and choose the best interventions to produce the best outcomes. For administrative decision-making, looking at what the needs are of each unit. When you think of the concepts of function, the symptoms, falls, pressure ulcers, and therapeutic self-care, if a patient comes in not managing to their function, they're short of breath, they have a pressure ulcer, and they don't know about managing their meds at all, there's more of a demand for nursing and clinical time. So this data could help looking at one unit versus another. What is the demand for nursing time? And also help nurse managers to advocate for staffing. Certainly data to support continuity of care and some predictive modeling and clinical intelligence. Having standardized data in EHRs will really help us in terms of understanding practice. And I did talk about health human resource management, but if we think of big data, and Lynn and I are really proponents that we need standardized data that supports nursing. We need other disciplines data in there, but nurses need to stand up and make sure that we have the data that we need and that will support looking at big data down the road. Next slide. So what do we know for certain? Leadership and clinical engagement are key. Where we've had success, where organizers implemented this and used the data, the leadership, they've talked about this data at the senior team, at the unit level, at the quality and safety and risk committees, we've had better success. We had one chief nurse that collected the data looking at a senior-friendly programming they were doing in their community and used the ADL data to present to their board on how well they were doing in preparing patients better for discharge. Partnerships are essential to success. We need to work with others. And I think the biggest thing is communicating the value of standards. Like I said, Lynn and I have been doing this for a long time. And whenever we meet with people and we talk about this, chief nurses and nursing leaders, this is important, this is important. And then somehow these big EHR implementations occur and they're not getting the data that they need to support looking at nursing practice in their organization. And I think that's a real opportunity for us all to learn, to know what questions to ask when we're implementing EHRs so that we have the data that we need to support clinical care, but also patient outcomes, because, as I always say, we're here for the people within the healthcare system. Next slide. So the adoption of national clinical standards, so you can talk about nursing data standards or clinical, it really allows for that consistent monitoring of outcomes. We can look at people across the continuum of care. And I just think that that is where we need to be in healthcare to support that whole thinking about a system. We can do some peer-to-peer national comparability to guide decision-making and inform funding requirements and really help us advocate for the role of nursing in the health of people. And then enabling individuals to use that consistently named, defined, and Lynn started out with like that at the beginning, that Clark and Lyon quote, named, defined, consistent, and measured data to help us manage illness and improve the health of the people that we provide care for. Next slide. So that's kind of where we wanted to be. I know it's a small group, so I know that you're not going to be hesitant to speak up and ask some questions or talk about what this might mean for practice. We have sites across Canada that are collecting this. We also have some sites that started collecting it, and then the nursing leaders changed and they implemented an upgrade in their EHR, and the questions weren't included, the CHOBIC questions. And I think that's it's because we really didn't bake in that understanding about the use of data. And that's certainly been one of our biggest challenges, I think. Lynn, what do you think?
Yeah, I mean, I think, well, there have been many, many challenges, and Peggy and I have written a few articles about some of the challenges along the way. But there's a lot of education, I think, that still needs to happen. You know, Peggy and I have spent a great deal of our time through our writing and presentations, really trying to convey the value proposition here. I mean, that's really been the crux of all of our work, is to say we want people to understand the potential value and the potential power of this for the system. I mean, really just thinking about, everybody talks about our system being broken and the kinds of things that we need to do to improve the system. This is a really foundational element, I think. So, I don't know.
Questions, comments, thoughts about what we're doing? We're certainly open to ideas.
Suggestions?
Do we have any questions? Do any of the students in HIMP 597